Good evening, good morning, and warm greetings to all participants who are joining us from India and across the globe. On behalf of the Telemedicine Society of India, it gives me an immense pleasure to welcome you to today's webinar, which is titled Telemedicine to AI, which is Building India's Digital Health Ecosystem. Uh, Healthcare India has been or is undergoing a remarkable digital transformation. What began as a teleconsultation 25 years ago, bridging distances, has now evolved into a comprehensive digital health ecosystem powered by government initiatives such as Ayushman Bharat Digital Mission, which is known as ABDM. And we have interoperable health records, remote monitoring, increasingly now artificial intelligence. So today we are not just talking about the technology, but we are discussing systems that would improve access, quality, affordability, and continuity of care for the millions. So this session would bring together national and international leaders in this particular domain of telehealth and digital health. So we will be looking about some of the growing role of AI in the area of teleophthalmology, tele-ICU, and regulatory governance. And while doing that, we would also talk about the telemedicine in India. So we are deeply honored to have the leadership of ISfTEH with us, Dr. Michelle and Mr. Frederick, and others also joining. I extend a warm welcome to all the panelists, the moderator, and who will guide us through this discussion on various aspects of digital health in India. I welcome all the participants and I encourage the participants to actively engage during the question and answer session. Please use the chat box for questions. With that, I once again welcome you all and look forward for stimulating and impactful discussions. Thank you. Now I invite Dr. Michelle for her opening remarks.
Thank you. I appreciate that. I'd like to say good day to everyone. I am honored to be here. I'm Dr. Michele Griffith, President of the International Society for Telemedicine and eHealth. And I'd like to specifically thank Dr. Sunil Shroff, President of the Telemedicine Society of India, and Dr. Uma for organizing this impactful webinar. I'm very much looking forward to the content, knowing that India has been on the vanguard of digital transformation of healthcare. I'd also like to thank the co-chairs and our national members of the International Society for Telemedicine for organizing this phenomenal year-long webinar where you will hear from different national societies across the world throughout the year regarding their digital health initiatives. Just to tell you and share with you a little bit about the International Society, if you are not familiar. Give me a minute to share my screen. And where is, oh, give me a minute. Oh my goodness, it was here. Let me find it. Happened again. Okay. Can you see my screen or no?
Not yet.
Not yet. Not yet. Okay, hold on.
Yep, it's coming.
How about now?
Yes.
Yes.
Perfect. There we go. Okay, so
Excellent.
Introducing the ISfTH Global Digital Health Network. This is what we are. Believe it or not, we were founded in 1997. We are almost 30 years old and we'll be celebrating 30 years of digital health impact. The International Society of Telemedicine and eHealth is a global nonprofit network advancing the adoption of telehealth, digital health, and virtual care. With members in over 100 countries, we connect healthcare professionals, researchers, innovators, and institutions to foster knowledge, exchange, and collaboration. We are recognized by the World Health Organization as a non-state actor, and as such, we support WHO's global digital health strategy. Our focus areas: global knowledge sharing, interdisciplinary collaboration, digital health education, accreditation and standards that align with international accreditation standards. We focus on policy, compliance, regulation, cross-border telehealth, capacity building, and of course, digital health equity. Our specific services: we have working groups on specialized topics, webinars, podcasts, international conferences, and events. We have a very robust education program, which includes digital health courses, ISfTeH endorsed programs, courses, and training. We have an annual student research contest and awards. We have ISfTeH global chapters, and of course, national, institutional, and corporate members. I mentioned that we support the Global Health Initiative, and we do collaborate and partner with Telehealth and Medicine Today Journal, where our members can publish relevant and significant articles. The strength of the ISfTEH is in strengthening our collaborative global partnerships. So as members, we have collaboration with policymakers, industry leaders, healthcare providers, academic partners, have some really interesting success stories with members working within our categories of membership and across categories. Of course, bridging the digital divide, we are committed to ensuring equitable access and very intentional about prioritizing telemedicine to underserved populations. So join the ISfTEH Digital Health Network. You can go to our website, isfTEH.org, to learn more. But we are about connecting care and transforming lives. Thank you.
Thank you, Michelle, for giving us this overview of ISfTH. Now I'd like to call upon Dr. Sunil Shroff, the President of Telemedicine Society of India, to just talk about what is TSI and how is telemedicine in India. Dr. Sunil Shroff, please.
Thank you. Thank you, Uma. Thank you, Michelle, for that overview. Telemedicine Society of India is just a little younger than the International Society of Telemedicine and eHealth. We've been around since year 2000, and it was a few very passionate people at that time who got together and felt that there was a need for a registered non-profit society which can promote telemedicine and medical informatics at that time, which is now digital health, of course. And they got together and formed the society. And we have, India is a huge country. We have 37 states and union territories. Telemedicine Society of India has 20 state chapters. So each state has its own unique kind of challenges. So that way we have one chapter in most of the major states of the country. We have 1,500 members, including as like you. We have, normal members, we have corporate members, student members, and so on. We have a lot of activities going on in the country. And every year we have our national conference, which is been held in fact, we have had partnership with ISTEH for, I think, over 15, 20 years now. We have very long association with you guys. And we share similar visions and mission of promoting digital health, especially to get reaching the last mile. It was during COVID that the Telemedicine Society of India really, did a lot of work related to capacity building and training. And as soon as pandemic was declared, Telemedicine Society of India, I think pandemic was declared on the 20th of March. And from 6th of April, Telemedicine Society of India started doing courses for doctors. And subsequently, the government of India came up with a template for telemedicine. And now it is part of the National Medical Commission, which is the National Medical Commission is our medical society. And telemedicine has become part of that. So we have a very good legal framework. Telemedicine Society of India contributed towards that legal framework. We are looking at having a version 2 of that legal framework. So like you, we have similar shared vision. with over 1,500 members, a large society. And we always look forward to your cooperation and a wonderful initiative from you, having this international webinars every month. And we look forward from learning from each other. So thank you again, Michelle, and thank you, Frederick, and thank you, Uma, and others. And I hope this will be a very engaging 1 hour of session. We have some excellent speakers who have huge amount of experience, especially after COVID has happened. I also want to mention that during COVID, we did almost 1 billion consultations, teleconsultations. I don't think so any country did as many consultations as we did, without any legal problems. So it has been a huge, learning experience from COVID. So look forward to this 1 hour of webinar, and of course, obviously, we'll have a lot of questions and answers, I'm sure. Thank you, Ma.
Thank you, Dr. Shroff, for giving an overview of what is TSI and what work we do. And now we'll move on to our next program of panel discussion. I would like to invite Dr. Sanjay Sharma, who will be the moderator. Dr. Sanjay Sharma is a podiatric surgeon, a serial entrepreneur. And we have panelist Dr. Kim, who is the Chief Medical Officer of Aravind Eye Care System, and he's also the past president of Telemedicine Society of India. I also would like to welcome Dr. Dhruv Joshi, who is the co-founder and CEO of Cloud Position, and Dr. Nambiar, a panelist who is a vice president of Telemedicine Society of India and CEO of IISc Medical School Foundation Hospital. Over to you, Dr. Sanjay, for an insightful panel discussion.
Thank you, Dr. Umashankar. It's been a privilege to be here addressing the global audience. Without much ado, let's get to the panel discussion. So, Dr. Kim, this is for you. You have been in the midst of teleophthalmology since the time I have known telemedicine. You have been working relentlessly with large companies within India outside of India. Teleophthalmology has expanded diabetic retinopathy screening in India. In your experience, if you could just give a background of the teleophthalmology work that you have been doing, and also share some of the biggest bottlenecks that you are finding in actually delivering ophthalmic care in today's AI world.
Thank you, Sanjay, and thank you, Uma, for inviting me for this national webinar. Very important and good learning platform. As an ophthalmology, ophthalmology is actually a low-hanging fruit for telemedicine to take up, because most of it is image-based, and so it becomes apt, just like in radiology, to use teleophthalmology. We have been engaged in the teleophthalmology for the last almost 23 years, setting up primary eye care centers for what we call as primary vision centers, which is manned by ophthalmic technicians who can screen patients and do a teleconsultation with the doctors in the tertiary hospitals. So today, we would say we are doing almost like 3,000 patients are being seen on each day. And this is becoming a most popular way of screening. And they say this is the best last mile connectivity in any healthcare intervention. And this is being replicated across the country and also in Bangladesh. This vision center concept has become really big. Post that, on the secondary level, we are doing this diabetic retinopathy screening again, which was being manually done. Now today, AI has taken a beautiful role in identifying diabetic patients in the diabetic retinopathy patients in the diabetic clinics. So patients need not go to the ophthalmologist, but just at the primary care, that is at the primary care physician or diabetologist office. We have put cameras, fundus cameras, train the technicians and ask them to take pictures. which AI is able to grade these images and make it referable or non-referable, and only those needs to be referred or sent to the hospitals or the ophthalmologist. So we were doing this even before with the manual, and post the AI deployment, unbelievably the number of AI identified, DR identified as almost went up by 8 times. And this is being today, scaled up across the country. We are also trying to see how the onus of identifying these diabetic retinopathy patients is with the diabetologists or the primary care physicians who are seeing this target population. So what made this possible, I would say it's because of the availability of these fundus cameras locally manufactured. And not only that, it's actually, there are 3 or 4 companies which are making cameras at a low cost. They were not only manufacturing them, but they were also driving this whole process of telescreening. So that's actually what has made it possible to scale it up. But what are the challenges even today? The acceptance and the compliance on the patients identified to follow up is still a problem. So we are working on that. Also working on the diabetologists or primary care physicians to take up this in a larger way, and also trying to bring awareness in the government sector to make it integrated with the primary health centers and CHCs for screening all these diabetic patients. Thank you.
Thanks, Dr. Kim. Following up, we have you mentioned that there have been several AI models, and there has been an increased detection of diabetic retinopathy and other ophthalmic ailments that we are seeing when the AI is deployed. We also have the challenge of the accuracy of the AI, the false negatives that might come in, or the false positives that might come in. How much of the performance degradation should we realistically expect when AI is deployed across your vision centers, not only from the Arvind's perspective, but there have been, as you mentioned, there have been several other players in the market today, especially in India and probably in other countries also. So what care as a ophthalmologist that you need to take care of when the AI deployed detections come into play?
Yeah, good question, Dr. Sanjay. It's really important because today there are, every AI company started with the DR screening as the major algorithm. Almost everybody, every engineering institution, they've been doing it. So it is important to choose the right algorithm, which is well validated. So one of the things that, many of these that are commercially available are undergoing through a lot of validation process. The other important factor is the CDCSO certification being available for these algorithms, because there are so many available today. So if these two are really considered, I think the fear of whatever we are using and many of these camera companies are using have undergone a lot of validation where the sensitivity and specificity are quite high. So the false negatives or false positives, we won't allow a little bit of false positives just to make sure that, you have a good inclusive of all patients who are on the borderline. So the most important factor is to ensure these algorithms that you choose are well validated and also certified. That's about it.
This leads to 2 questions, Dr. Kim. One, you talked about CDSCO, which is a licensing body in India that I would say for all the software as a device kind of a platform. So would these algorithms come under the software as a device, and how scalable it is beyond India? Because most of the validation, if it has happened in India, or if the validation of these algorithms has happened outside of India, and the companies would want to come into India and deploy them, or the companies which has validated in India would want to deploy it outside of India, is that something, a challenge that we are seeing, or is it really borderless when we are deploying this AI algorithms across?
So
So
definitely, it is needs to be evaluated on because the ethnic changes in these patients, especially related to diabetic retinopathy. There is a lot of pigmentary changes that happens in different ethnic populations. It needs to be validated in those countries, and many of these algorithms also you have to be mindful that they are camera agnostic. So if you're sure, you have to understand for which camera these algorithms are trained for or validated for has to be looked at. And definitely, it is not borderless. I would say it has to be evaluated based on that ethnic population before you can use it in any place.
awesome. So, Dr. Kim, I should get back to you once we are again discussing the regulations and the digital health policy and how it has impacted teleophthalmology also. But now let me move on to Dr. Dhruv. Dr. Dhruv, welcome to the panel. You've been working on the tele ICU and probably in India and other countries also. And tele ICU promises a specialist access to the undeserved areas. What has been if you can just give a brief about what you have been doing in India and outside of India, and also share the biggest limiting factors, whether it is technology or human resources or hospital culture, which is a barrier in implementing tele ICUs.
Thank you, Dr. Sharma, and it is my privilege to share this stage with all the luminaries here. Thank you very much. Quick introduction. I am a pulmonologist and an intensivist by training. I used to be in the US working here, then moved back to India to start Cloud Physician, which we have now expanded. And now I, in fact, expanded back to the US as well. So just in terms of our presence, we are present in India, in Africa, and the US currently. Those are the places that we work in. Very quickly, the area that we focus on is the use of digital care, of virtual care, and of AI in the inpatient spectrum. Right? We all know the applications of telemedicine in the outpatient spectrum. Of course, we saw the need during COVID as well. However, our particular focus is the inpatient spectrum, and that expands not just in the ICU, which is a critical area in any hospital, but beyond that to the emergency room, to neonatal ICUs, to pediatric ICUs, and the entire inpatient spectrum where you have high acuity patients, and perhaps quite often can be challenged with access to expertise all the time. And these are all settings where you often need a specialist, whether it's an intensivist or a neonatologist or an ER physician at the drop of a second. And perhaps that is places where telemedicine or virtual care can come in and help. And so that's the area that we focus in. We're in about 300 hospitals across India. We have a presence in Nigeria and Kenya and the US as well. And this is the area that we focus on, where we deploy technology into inpatient units and then connect them with the expertise that is needed. Right. And while we started by connecting them with expertise in the form of, expert doctors like myself and my colleagues, we've even gone beyond to leveraging AI, which actually is used as a tool by these expert doctors to detect and pick up issues amongst patients and address them quickly. Your question was quite telling. Where is the biggest challenge? Is it in the technology? Is it in the available of expertise, or is it in the culture? I can tell you that technology moves much faster than the other two, and is moving much faster than the other two. So I think technological problems, and I've seen this from starting in India itself, where initially connectivity and things of that nature were a problem, which increasingly become rarer and rarer of an issue in terms of just having availability of data and having connectivity. I think the problems that are more entrenched and harder to address are quite often those around hospital culture, which involves change management, which involves bringing about a culture of collaborative care where you may not necessarily always have the physical presence of some of your colleagues. I think those are some of the cultural issues that we constantly deal with. Of course, we overcome them as well, but I think it requires a structural process for us, an onboarding process, a training process, an engagement process continuously that we work with people to overcome some of these structural issues. From an availability of talent, I think that is always going to be a challenge. That is never not going to go away. I think that is the basis on which the entire telemedicine movement started, was that number one, you have a shortage of the expertise that you need. Number two, they are not homogeneously distributed; they are heterogeneously distributed. So you may have some areas where you have a lot of expertise and others that you don't have. And so I think that is where telemedicine and AI becomes a great leveler. I really enjoyed what Dr. Kim was talking about, the power of AI and technology in this space. We are seeing similar changes in the inpatient spectrum as well, and particularly with the use of cameras. One of the things with the entire tele-ICU, tele-ER movement has been that we have had to install cameras in these units. And now, with these cameras available here, we have been able to build algorithms that would automatically detect changes and deteriorations in patients, which ordinarily would have needed either a person to physically view it or a person to virtually view it, and which we were doing via virtual visits. However, to your point, you don't always have, even for a virtual visit, the availability of people 24/7 in critical scenarios. So, can we use algorithms to detect, deteriorations in patients, whether it is, your work of breathing is changing, whether a patient is getting more delirious, whether a patient is more sedated, whether a baby is, pulling out a life-saving tube. Can we use algorithms to detect these? That is the space that we are in. I can tell you that since we are present in the US, and actually I'm here right now in San Francisco, we are seeing a movement of hospitals here in the US towards building smart rooms, right? And these smart rooms are getting enabled by the ability to have virtual care, the enabled ability to have cameras, and then the ability to then build an AI on top of these cameras to actually make them smarter and smarter. So can we start using raw, video footage to and convert that into clinical intelligence, which can support nurses and doctors? We're seeing increasingly a movement towards that, and that's very much a space that we find ourselves in. So I'll pause there, but thank you for your
Thanks, Dhruv. So you actually, I had that question in terms of 5 years down the line, do we see AI augmenting the remote intensivists? And then actually you answered that question. An interesting thought came in, or a question came in with the AI, the chat GPTs, the LLMs coming in into the play, and most of the physicians, doctors like us accepting them today. We still we also go out to ChatGPT to ask questions on how should it be done. So with that being the case, has the adoption of tele ICU amongst the physicians, amongst the nurses, paramedics increased after the invasion of LLMs?
I think, and I can tell you that I have seen this in the last 2 years. We've been in the tele ICU space for. I've been in this space for almost a decade and a half. But the rate of adoption that we have seen in technology amongst providers, whether it is doctors and nurses in the last 2 years, has been far, far greater than I've ever seen before. Perhaps the only other time that we had seen such a spike was during the COVID period. Uh, I whether it is LLMs, whether it is scribing technology, having using audio scribes to automatically document conversations with patients. whether it is the use of open evidence of late, which has come through. I think we have seen a pretty big shift in the behavior of practitioners, where we have seen that increasingly. In fact, I almost don't know any doctor or nurse that does not use some form of whether it's LLM or some other technology to aid them. So I think that has been a really positive change, and I think that what that has augured is it is augured in an era where we'll see adoption curves be a little bit steeper than we have previously seen them. Right? And I think that's a good thing overall for the ecosystem.
Awesome. Dhruv, I'll get back to you once we discuss the regulations and digital health policy with Dr. Uma. And Dr. Uma, you have been at the helm and you are heading one of the institutes which would be the future of medical technology and healthcare in India at the ISc School of Medicine at Bangalore. So if you can just give a brief about what you have been up to at the ISc School of Medicine, and also the newer regulations that has been coming. It could be ABDM or DPDP Act. What are these regulations that has come in? How would it impact the companies who are developing telemedicine or digital health or AI solutions, and how it will be impacting to the patient also? If you can just give a brief background.
So thank you, Dr. Sanjay. So, I mean, just a one-liner about the medical school that we are setting up at the Indian Institute of Science is trying to create a center of excellence in India where we can, from the hospitals, drive medical technology innovation and set up incubation centers which are, driven by doctors, and really have top-of-the-line tech-based institute for healthcare research. And as we speak, we are also aiming to be a fully digital hospital. So therefore, it's a tall ask, but then let us see how we can deliver it. So that's what it is. Now, coming to you talked about the regulations that the government of India is coming up with, and whether it is the Ayushman Bharat Digital Health Mission or the DPDP Act. It is, I think we've had, if you remember, the first EMR standards in the country were published in 2016-17. So it's not that going digital is not known to the powers that there are, and the government is aware of it. And also people, the larger ecosystems have been going digital. And you just heard from Dr. Kim how Aravind Eye Hospital and various other institutes have been in the space. But India is a large country and also very, very diverse and heterogeneous in the way we deliver healthcare as well as the way population seeks healthcare. During COVID, the importance of the digital ecosystem and especially telemedicine became very popular, and that's around the time when digital, the telemedicine regulations and the guidelines came about. So there are multiple guidelines that have been instituted by the government of India. Now, if I were to look at some of the key things, when the telemedicine guidelines came about, the importance of identification of a patient and a doctor from a remote location. People understood that when you do a digital consult, how it is very important to actually have the identification verified for the doctor as well as the patient. Similarly, how do you prescribe? How do you do an e-prescription? How do you validate that? So some of these important regulations here. I must talk about the ABDM. Now, it's a very, very, I would say, one of the most ambitious projects that any government could undertake. And that also in a scenario when in India, health is governed, like it's regulated. There are guidelines from the center, but every state implements its own healthcare, manages its own entire healthcare governance scheme. So it's not necessary that what the center lays out needs to be implemented by each state. So they modify in their own manner. But the biggest, or I would say the best thing about ABDM is that in addition to CDSCO giving softwares a license, it also, ABDM has a sandbox in which all the softwares have to get tested for interoperability. Now, this is a big game changer if you ask me. So if we need to have a patient having a single longitudinal electronic health record, and we are a mobile population, we move across. Interoperability across systems is what is going to make this possible. So this is an extremely important step. Now, where are the challenges here? The older hospitals, which actually went to digital many years ago, they have legacy systems which don't speak to each other. Now, the challenge is for those people. For the hospitals that are now getting into adoption of digital technology, it's easier because there are more agile technologies to choose from. They they actually can factor all this interoperability. And when we speak to the vendors, where whose machines have a software, who and which all we are going to take in the hospital, we can mandate that the software must speak to our EMR and to each other. So that's where this whole interoperability space will go. In addition to boost the safety, security, and privacy around patients' data, the DPDP Act has now, the Act came into 23 and it is now the new rules and regulations have been implemented in 2025. This gives a sense of confidence to all the providers, and more than the providers, to the patient, that your data is secure, that people cannot misuse. It gives the power to the patient because it is only through the patient's consent that you can use that data. So putting the power in the hands of an individual citizen about their healthcare data management is a bold move, and of course it requires a lot of compliance. So we will talk about it, but I think these are some of the important uh, things that have happened to ensure that Indian healthcare is going to grow digitally, and it is more or less moving towards that point where we'll reach that critical mass where technology will really leapfrog and the entire system will suddenly become very accessible to everybody. So it's going to be one of its kind system, and for 1.5 billion people, if you can have digital health records and seamless, that would be great.
Hi, thanks, Dr. Ma. I want to get to the next question along with the question that was asked, which is a generalized question that came in from the one of the audiences. We are seeing an integration of AI into the EMRs that we are seeing. We are also seeing, a lot of patients coming to us with the ChatGPT data. We are also seeing, like Dr. Dhruv's company, where AI is being implemented in various of the modules. Like it could be tele ICU, or for me, it would be tele wound care, or where AI is implemented for the diabetic foot conditions. So, and Dr. Kim also mentioned about the Cedasco, where these applications are kind of regulated as software as a device perspective. So with all this, how would you look at AI playing a role? Because you are someone who will be having all these startups, all these incubating companies in your school, 1 year down the line, setting up all these solutions. So how do you see AI being regulated and beneficial for the public in general, with all these applications, rules, Cedasco rules, all those things coming up? It looks very, too many things to kind of address.
So, starting on an optimistic note, yes, AI is here to stay. Having said that, let me also be the devil's advocate and tell you that we have a long way to go. While there are small islands of success, wherever there has been reliable data available to us for a long term, and where algorithms could be validated and tested across larger uh, data sets, we have, like say, how Dr. Kim is using or Dhruv is using. some of these AI algorithms, it is possible to use in some settings. But it is at this moment not for all. We are still far off from proper data collection. Our data collection itself in various healthcare settings is really falls short of what is the desired level of accuracy and timeliness that we should. So, as healthcare providers, one of the things is that we need to look at this responsibly, because if I want to use AI algorithms in future, it behoves on me that I today invest my time and tell all my people who are in my organization to ensure that they capture accurate data. Now, we could be using a lot of technology, and today a lot of technology is available to enable this data capturing. So that is, I would say, a very important aspect of how AI will help us in future. AI is not replacing any clinician's job or anything. I mean, it will only be an adjunct to what a clinician is doing. We still have to have clinicians who know how to use the decision support that is given by the various algorithms. So this is something which is always going to be a work in progress, because medicine is number one. It remains, although large part is objective, but there is also a significant part that is subjective. There still is a lot of interpretation that needs not just technology, but a lot of, I would say, the intellect that the experienced physicians bring onto the table. So it will always be an extremely useful adjunct. Where it will help is, it is providing physicians more time to do quality work, to spend less time on the mundane work that they have to do. Similarly, handling the crunch of the human resource. There are areas where we do not have physicians. So if you want to look at the level where at remote, you can use screening applications, and then it gets, the data is then shared with the larger hospital and the specialist. So at that level you can use technology, and this is where we will really improve access. And also, when you start using it at a larger scale, it will also bring down the cost of healthcare. So human resource management in the healthcare sector would be largely benefited by use of these AI-based applications. And a lot of startups today, I mean, they know that they will do small applications and integrate. So all that, I look at it as something that will be beneficial to the entire ecosystem, but there will be a lot of filters that have to be applied in place by all of us to see that we use it very judiciously right from start. Over to you.
Yeah, thanks, Dr. Uma. And I think Dr. Kim has left here. Informed that he had another assignment that he has to go to. But can I pull in Dr. Sunil for a one quick question? Is he there?
Yes, thanks, Sanjay.
Yeah,
I
Dr.
actually,
Sunil. Yeah,
please.
Dr. Sunil, from the TSI perspective, what regulatory principles must remain non-negotiable to protect patient safety in this flux of AI applications that is coming into the space?
I think, privacy is very important, and that is not non-negotiable, totally. The data of patients and the privacy of the patient is at utmost importance, and that can never be negotiated. Besides that, obviously, use of AI itself, are you going to use it as just for, supporting a diagnosis, or actually making treatment happen? And that question we need to really ask. And I feel that is not negotiable either. So these are two important areas which I think, more and more as we go forward, the AI is going to be a bigger challenge, especially, in mental health. The mental health chatbots are today, giving those answers and directly trying to get, involved in the treatment itself. Because there are certain, defined areas of treatment for certain conditions where they may help. But are we going to allow that to happen as clinicians? Is a bigger question. Sometimes it may be difficult for us to stop this because sometimes the consumer market drives change, right? Change itself. But this is one area which we really need to look at seriously and put safeguards, put guards there for patients to be protected. We know the problems of ChatGPTs and Google giving answers. We've seen some of the problems there has been, in this ecosystem. So I think these are the areas which I think are not negotiable.
Dhruv, one question for you. I think we are coming into 8:15, 8:16 already. We'll have some time for the Q&A also. Let's assuming there is an AI recommendation during for a physician or to a doctor in the ICU to recommend something, and there is a wrong clinical decision. Today, we all know that the liability lies with the physician, but how should it be in in an idealistic situation? How should the liability be distributed? Clinician or the platform or the developer? How? What do you think about it? And where is the world going in this regard?
Yeah, I think, I firstly completely agree with what Dr. Uma and Dr. Shroff said, right? I think some basic parameters like privacy, consent, etc. These are non-negotiable. And like Dr. Uma also mentioned, right, that this is currently where we are with the use of AI is as an adjunctive tool. I mean, we've been hearing about, at least I've been hearing for the last 10 years that, radiologists are going to become extinct, and radiologists are not becoming extinct. In fact, we don't have enough of them, right? And so, even though you have so much of AI radiology, perhaps that's a field where you have the most use of AI in healthcare. Yet you find the need for a radiologist only going up, because the fact of the matter is that you still need judgment. You still need empathy. You still need the subjective aspects of healthcare, which AI is not ready for. But it is a great tool to support radiologists. Fact of the matter is that a radiologist using AI is far more efficient and far better at their job than one not using it. To more specifically to your question, I think this is an evolving ecosystem right now in terms of regulation. Dr. Kim had mentioned, right, that what is the standard that we need to have in terms of sensitivity or specificity. I would even take that question further. Is it sensitivity and specificity that we need to be measuring? Do we need to measure an F1 score? Do we need to measure accuracy, recall, etc.? Right? What kind of data set has it been trained on? Fact of the matter is that there is no one size fits all. For diabetic retinopathy, actually, a certain standard may apply, which may not necessarily apply to detecting patient deterioration in another context. It's very interesting. We work closely with the FDA, and I had a conversation with the team there last week, and they were very forthright in telling us that we are not currently equipped to regulate everything that is coming through. Right, so we almost need to work with partners in the ecosystem who are building these different solutions to understand what would protect the patient, what would keep patient safety paramount, yet be useful to a doctor or a clinician, and then decide what is that parameter that would be the regulatory parameter. So it's very interesting. It's almost like a partnership that we're having with regulatory authorities right now. Uh, More specifically to the question of liability, I think at least in the near term, Sanjay, that question is, you had answered it yourself in your question itself, is that it is going to be used as an adjunctive tool. There is going to be a human in the loop. Judgment is going to have to be exercised by the doctor, and as a consequence of that, liability will be lie with the person that's exercising, the human being that's exercising that judgment, right? So I think that is where we are right now. As these regulatory parameters evolve, we may see how platforms will start becoming more and more liable, and should become more and more liable. Right now, everyone will put a disclaimer and say that this is an adjunctive tool. At the end of the day, you use your judgment. And that is still very helpful. Let's not take away from that. That tool itself is still very helpful and can help us. But that liability still lies with the practicing physician at this point in time. I do see it evolving, Sanjay, to your point. I do see it evolving where we are going to get to a point where some of these platforms will get more, we'll have more standards in place, more regulation in place, and perhaps more liability in place for platforms as well.
Thanks, Dhruv. I hope we don't see patients suing the platforms in going in the going in the future, and that is what we're looking
No,
at.
you can expect some of that to happen.
Yeah.
Yeah. And I mean, I would want to just add a line to what
Sure.
Dhruv was saying is when I discuss with the software solution providers to my hospital, I ask them to sign on vicarious liability in case of data breach where we have no control over it. See, because today you have to understand that as healthcare provider, it's no longer just the hospital or the doctor or the direct healthcare providing team. The technology providers, the not only the technology providers, but the telecom network providers on whom we depend on all these Wi-Fi networks and everything. All of them are part of this care provision. So a mistake can happen because of problem in either of these stakeholders. And what eventually ends up as a problem in a patient or a complication or a data breach or the hospital getting sued. But the government or all these regulations that we mentioned, and we started with all the different things that the Indian government is doing, nowhere has anyone else been termed accountable except the hospital as a data fiduciary. So the only significant data fiduciary identified is the hospital or the healthcare provider. It could be a clinician in a clinic or a hospital, whatever. But between us, now we know that we are dealing with a healthcare related decision which is taken by multiple stakeholders on one side. So each stakeholder must share that liability, isn't it? So, I mean, I firmly believe that some amount of vicarious liability at least needs to be shared by the EMR solution provider or the person who's, providing me my network. So in whatever possible, I try to get the software companies to sign up with me on this vicarious liability clause with a lot of resistance from them, I can tell you. Some of them
That's an
just do not want to
interesting.
sign this. But if we don't make this beginning, it is difficult. And at some point, I'm hoping that with the speed at which our IT as well as the healthcare ministries are going over these regulations and modifying them so quickly, and the additions like from 2017 till 2025, we've seen significant version improvements in all this. And I'm sure this will also get addressed.
So,
Just,
Uma,
you know,
as you are at it, we have a question from Rahul. How will AI-enabled telemedicine platform ensure compliance with India's DPDP Act, particularly in the context of evidence-based research, given that the current act emphasizes more on hospital and institutional data while providing limited guidance on the use of community-based public health data for research purposes? I think that question is visible to
there are
you
a couple
also.
of things. Yeah. So a couple of things that are, which are easily addressed in the current DPDP Act and which you need to really look at the compliance of a telemedicine provider solution. One, as I mentioned at the beginning, is establishing the identity of the people at both ends and establishing the identity of a patient through the Aadhaar card, or if it's a patient's attendant, then through these identity, the government approved identities, and the doctor's identity through the registry for doctors, whether it is a state registry or whether it is a central registry. So that is one. Second is when you talk about this data, he said about use of data for research. You need to have, so for this, important thing is consent framework. So establishing, taking the consent from the patient, and consent, one is there is a framework given by the DPDP Act for consent, how you will use the patient's data, how you will use for anonymized data for research. So that anonymization, if the patient has not giving you consent and patient has the freedom to opt out of giving you any consent for
Can you keep this
for
short, your
that we
answers?
have to make sure that this is used. So DPDP Act actually gives you some of these that can be used. Now, where it probably is not very clear, like they say that you use the data for 3 years. And you know that for some diseases, 3 years of keeping the data, retention of data for 3 years is not enough. If a person has malignancy, if a patient has chronic diseases, any NCD, you need to keep the patient's data for longer. So how will you store that data? Where will you store that data? And for how long? I think some of these will get modified as we go, but as individuals, we need to take a call. Like if I'm running a hospital, I need to take a call that I will keep the data for how many ever years that I want to do. So there are some of those things which still need to get clarity.
Can we kindly keep the answers short so that you can take all the questions in the chat?
Sorry.
Any other questions do we have? We have
Sanjay,
about
there are some questions in the chat, please take
In
that.
the chat, there's some question.
No,
See, there is one chat.
there.
Would you like me to read the questions, Sanjay?
Yeah, I'm able to read, but after Rahul, I don't see any other questions.
There's one question in this from Mausami Singh. She says a very general question.
That got question that I asked already.
Asked, okay, good.
I asked to Dhruv already.
I want to ask Dhruv one question myself.
Yeah.
We've seen this cross-border development of teleradiology significantly. Do you see a similar trajectory of growth in tele-ICU, Dhruv, with some of the challenges being bigger in tele-ICU care? Are you already seeing it? I'm not sure. And what do you see how the future?
Yeah, we are already seeing some of it, Dr. Shroff. That having been said, there remain some structural barriers around cross-border tele-ICU, just around licensing and credentialing and having local licensing, etc. Not insurmountable. We do address some of these particularly in certain geographies. And I see that we'll continue to do that, right? So I do see that that is a trend that will sort of continue. There are also some economic factors as well associated with it. Different places pay differently. So is it going to be applicable to have an expert from one country be able to consult in another one? Would it be incentive enough for that person? Some of these are the challenges that we face. I do think that some of these structural challenges will not entirely go away, Dr. Shroff. So we will see some some resistance here. That having been said, we'll overall see a movement in the direction where we'll see more sort of cross-border interactions. I will say the one thing that is going to travel cross borders more seamlessly is the technology, right? I think just some of the the AI algorithms that are being built, perhaps in one region, may be applicable in another one. We are seeing a lot of that already happen. Also, I can tell you that you had seen most of the innovation actually when it came to technology come from the West, whether it was the US or around there. I think we are going to see that also a little bit evolve simply because the US does not have enough data. For the development of AI, you need data, right? And you need high quality data and the ability to collect that data. And I think we're going to see other geographies come to prominence, particularly places like India, where we have a lot of data. Right? So we have the ability to build algorithms quicker and faster than places that have a paucity of data, even if they are more technologically advanced sometimes.
Thank you. Thank you, Dhruv.
Hey, thank you. I think we are just 1 minute. I would hand it over back to Dr. Umashankar to kind of conclude the sessions.
Thank you, Dr. Sanjay, for moderating the session very well, and thank you all the panelists. It was a wonderful discussion. Now, I would like to invite Mr. Frederick for concluding the session and for further announcements.
Yes, thank you very much, Umashankar, and thank you to all our speakers and the panelists and our moderator for this session, giving, well, I guess, a tip of the iceberg of everything that has happened, is happening in India. We know for many years that lots has been going on in India. The Telemedicine Society of India is the national member for India in the International Society. And so we followed all your initiatives and events for many, many years. So thank you for bringing this session today. This is part of a series of webinars that is organized and presented by our national member organizations. And we will actually have our next one next month in March, which will be presented by the Nigerian Society for Telemedicine and eHealth. So we'll be announcing more information about that very soon. And of course, we look forward to welcome everyone back for that one. So look out for the announcements and the dates and the details of that. And that's it for now. Thank you all very much for joining. This webinar will also be posted soon on the ISfTEH YouTube channel, where you can watch it or share it with your colleagues. Thank you all, and see you in the next
Thank you.
session.
Thank you all. Have a good day.